He had history of hospitalization for hematemesis and severe anemia. UTI endoscopy was done at that time, and the patient was discharged after attaining normal hematocrit and hemodynamic stability. He is alcohol consumer, chronic smoker, and based on the clinical feature, our provisional diagnosis was gastrojejunocolic fistula, and the patient was admitted for further evaluation. For the evaluation of nutritional status, we use subjective and objective tools. His ECOG performance status was 1. He was followed, and according to subjective global assessment, he fall under severe malnourished and had evidence of severe wasting. So he fall under the high risk patient for malnutrition according to the MOS tool. So dietitian consultation was done. For the nutritional management, we kept the patient meal per oral. Nasogastric decompression was done. Total daily calorie requirement was calculated, which was 200 kilocalorie per day. And initially 50% of total kilocalorie was supplemented via total parental nutrition to avoid refeeding syndrome. And at the end of 2 weeks, we were able to give 100% of calorie requirement via total parental nutrition. At the same time, we did physiotherapy consultation for this patient. The patient was having muscle strengthening exercise, range of motion exercise, incentive spirometry, and aerobic exercise. For the confirmation of the diagnosis of our case, we did CT abdomen and pelvis with oral contrast. And the CT revealed there was a communicating tract in between the mass arising from the greater curvature of the stomach that was communicating to the proximal part of jejunum and distal colon with simultaneous opacification, which indicates the gastrojejunocolic fistula. And on UTI endoscopy, there was also proliferative mass at the greater curvature of stomach with feculent content. And we had multidisciplinary meeting at our center. And for this patient, we planned 3-stage surgery. We planned diverting colostomy proximal to the fistula with feeding jejunostomy. The rationale behind this was we think that diarrhea and malnutrition in gastrojejunocolic fistula patient is due to rapid influx of gastric content into the colon, which is partially right. But what actually happens is the reflux of the colonic content in the jejunum causing jejunitis and severe diarrhea, and the feculent content in the reflux of the feculent content within the stomach causes gastrodiurenitis and feculent vomitus that is very distressful for the patient, and patient do not want to eat. So there will be severe malnutrition, and there will be. So to overcome this reflux of the colonic content within the jejunum and stomach, we did we did diverging colostomy distal proximal to the fistula tract. Feeding jejunostomy was done. Biopsy from the greater curvature was taken. In post-operative rate, we shifted total parental nutrition to the feeding jejunostomy, and there was no feculent odor, and the appetite of patient was improved, and he gained weight. And the biopsy from the greater curvature mass came to be adenocarcinoma. Again, we had multidisciplinary meeting, and we planned for upfront surgery for this patient. And we did soft total gastrectomy with segmental resection of transverse colon involving part of jejunum. In post-operative period also, we continued feeding via feeding jejunostomy, and post physiotherapy was also continued. This is the cut section of the stomach, showing the ulceral proliferative mass at the greater curvature of the stomach, which has got fistula tract at the center. This is the same specimen. The caudal part is the transected part of the stomach, and that middle one is transverse colon, and distal one is the jejunum. There is the communication between stomach, transverse colon, and jejunum. In pathology lab, surprisingly, there was the mass in the transverse colon, which was 18 to 9 centimeter, grayish white in color, hard, and there was also which was encroaching to the stomach, not the mass of the stomach that was encroaching to the colon. So our primary site of adenocarcinoma was colon, which was causing fistula in between the stomach and jejunum. On 10th post-operative day, the patient presented with gastrocutaneous fistula. We managed him conservatively. And after 4 months, he again presented with the prolapsed colostomy with features of acute intestinal obstruction. Emergency exploratory laparotomy was done with resection of prolapsed colostomy with the primary uterine anastomosis. Adjuvant chemotherapy is completed for this patient, and the patient is doing well. In Western world, surgery for colon cancer is common. So transverse colon adenocarcinoma causing fistula is also common, with incidence of 0.3 to 0.4%. And in our world, the surgery for gastric cancer is common. That's why the cause of enteroenteric fistula is due to gastric cancer. This patient usually present with diarrhea, fecal vomiting, and weight loss. In 1930s, three-stage surgical approach was popularized. The main disadvantage of this approach was the patient has to go through 3 major surgical interventions. In 1941, Lehes proposed 2-stage procedure, which became widely accepted and preferred treatment since it has low mortality and morbidity. With recent advance in total parenteral nutrition, along with improvement of intensive care, 1-stage in-blood resection is the procedure of choice that further decrease the mortality and morbidity for the patient. And in our center, we perform 3-stage procedure since the patient was severely malnourished, and there was diagnostic dilemma during the treatment process until definitive surgery, and the consequences of malnutrition were addressed by the help of dietitian. Physiotherapists, intensivists, and nursing play vital role in the treatment of the patient, and the unexpected complication like gastrocutaneous fistula was managed conservatively, and the patient withstood well the emergency surgery for prolapsed colostomy, which is the most common complication for transverse colostomy, and he has also completed adjuvant chemotherapy. Learning point from this is endoscopy with CT abdominal pelvis should be integral part of diagnosis in adult patient with GI bleeding and anemia. Multidisciplinary meetings should be conducted for the better outcome of the patient, and the proper nutritional assessment should be done before undergoing the surgical procedure for the patient. Thank you.
Thank you very much, Dr.Arati. So the floor is open for questions.
I think well managed this case, very complicated. You rarely see this kind of case in your life. Only thing is that the patient is lucky to afford this parenteral nutrition. So perhaps in early jejunocolic feeding would have been, if the patient can afford. But you've done a good job. Thank you.
I think I should congratulate to the GI team here. So very difficult case. What was the intraoperative planning for the nodal dissection? Because initially we thought that it may be the gastric cancer going into the colon, but you did a total gastrectomy. The nodal harvesting will be little different than the gastric and colon. So what was planned intraoperatively?
Actually, thank you for the question. Actually, it's quite difficult case to discuss what we have done before after surgery, because the theme of this presentation is mainly not the surgeon should only do the surgery. The thing is how to integrate all the treatment part in the surgery. Because we started with the nutrition, we addressed the physiotherapy, dietitian, multidisciplinary, again surgery, again complication. conservative management, again oncology treatment. So it is a very nice learning for the young surgeons and the residents. It's very important. As for your question, it was a gastric with the, we feel it is a palliative treatment. When we go inside, we thought we do the palliative surgery. Thank you.
Dr. Malla, yep, here. Yeah, like we said, it's always very difficult to manage a very complicated fistula, something like this, and then you've done it pretty well. The only thing that I would differ from your management is after you've done the first surgery of divergent colostomy and feeding jejunostomy, I would rather put a neoadjuvant chemotherapy for oxaliplatin based chemotherapy for 4 cycles, and then you follow by the furthermore surgery. Yeah. Otherwise, but anyway, it's really nicely done, and then finally read out, and we have a very nice outcome.
We already have a sick, but we have an oncology meeting every week.
I think this is not a curative surgery, right?
It is a balance.
Isn't that
It's a
bleeding
bad thing,
also?
and then you just try to prolong that. So the question of lymph node, is it very important here?
I don't think it is a palliative. If the patient is still alive and doing fine, I think treatment is okay.
In retrospect, you probably would have thought it was colon, because a year earlier he had upper endoscopy, which was normal, and he had a hemoglobin of 3.8. So really at that time it would have been most wise to have had a colonoscopy. And so, I mean, if it was a gastric cancer, you'd have seen it a year earlier. So it makes sense that it was a colon cancer. So you're right. I mean, on the one hand, it's a palliative procedure. On the other hand, also when you're resecting for colon cancer, you want to get like 12 lymph nodes. So maybe you would have, taken a bigger mesenteric margin for more nodes, but in all likelihood, it's going to be palliative.
I think that's a learning for us also when you have a melena. And we didn't have the diagnosis. I think we have to search more. I think we'll come